when we do see KRAS G12c patients in our clinic, would you offer, what would be your standard first-line therapy? Would you offer these patients sotorasib first-line, or would you still go with, standard chemotherapy plus or minus immunotherapy?
So at this point, I would go with chemotherapy plus immunotherapy, just because the data that we have on sotorasib, again, first of all, the data was mainly done in second line. So the drug has been tested. So the response rate that I mentioned you and duration of response, this is all for patients who have previously failed chemotherapy. So my first line of choice is chemotherapy plus immunotherapy. Or immunotherapy by itself if the PD-L1 expression is high, and I tend to just use KRAS targeted drugs for second line. The clinical trial that I have with adagrasib does have an arm for untreated patients, and I am very comfortable putting my patients on a clinical trial, because in this situation, we don't know what the efficacy is in first line. But we got to get that information at some point.
Exactly.
And I'm very comfortable doing it, because we do scans within 6 weeks, and if things don't work, we can always come off the study and go on chemotherapy. And so that's what I do for my patients. I think we might be able to move the drug in first line. Would it be in combination with chemotherapy? I think we don't know yet. I think the one subset of patients which may be separated from the all KRAS patients as patients who also have a STK11 mutation that you just mentioned. There's some evidence that maybe the KRAS drugs are more effective in patients with STK11 mutations, but it's controversial, because there are some studies who say yes and some studies who say no.